to speaker view if you have not done so already. Following the presidential election last Tuesday and thinking about this Lunch and Learn program, I wasn't sure how we would be able to give our full attention to what I knew would be another excellent speaker and the opportunity to learn about an important subject. One very long week later, we do have an election result, although not yet certified. I realize, though, that I'm grateful on so many levels, but most importantly, that I am a citizen of these great United States, where every vote counts, and that nearly 150 million people exercise their right to vote this year, despite incredible challenges. Now it's my pleasure to call on Francie to help us acknowledge how we Americans must be feeling at this moment in time, no matter what your political preference.
Thank you so much, so very much, Nancy. And as I was thinking what prayer, what blessing, or even what song, we would ultimately pick, God Bless America came to mind. As many of you may not know, God Bless America was written by Irving Berlin, who came to this country as a lad of 5 and spent the rest of his very, very long life lauding his adopted country. Now, another fact that you may not know was that he originally wrote the melody and most of the lyrics for God Bless America in 1918. I was really quite taken with this early date. And in 1939, actually in 1938, he wrote the lyrics to all the lyrics that we know. And one of my earliest memories was remembering Kate Smith on her TV variety show saying, "Hello, everybody," and then singing God Bless America. So what I'm going to do without further ado is turn this over to David Diskin, who found a wonderful, wonderful choral rendition of God Bless America. And then we all can join in praising the fact that we are all Americans. So thank you very much.
Okay, give me a second here.
Now it disappeared. I don't know.
Okay, let me know if you can see and well, especially hear it. People hearing this?
Yes.
Okay, there you
All
have it.
right. That was absolutely beautiful.
Well, I don't know if you know, but Berlin lived in Southwest Washington for a good part of his life, Irving Berlin.
Oh,
Buildings that were torn down.
thank you. Thank you. Well, thank you, David, for just a beautiful rendition of that song. It always brings tears to my eyes listening to it. And thank you, Francie, as always, for your wonderful guidance. You're a superb teacher and always set just the right tone for moving us forward in a positive direction. So let me explain the format of the rest of today's program. I will shortly be introducing our guest speaker, Andrew Narva, who will then give his presentation, which will be followed by the question and answer period moderated by Sid Booth. Please use the chat function to submit your questions to our speaker, and be sure to send them to everyone so we can all see them. At around 1 p.m., my co-chair Phyllis will introduce the second half of our program. David Diskin, our very able Zoom host, will then split the group into breakout rooms to enable us to socialize and discuss today's topic. We want to thank our speaker for providing questions to start your discussions off. There will be posted, these will be posted in the chat function. At around 1:25, we will gather together for some concluding remarks. Just a few housekeeping reminders. Please keep yourselves muted and now turn off your video. We would appreciate your continuing to do this until we get to the breakout rooms. And in order to avoid sound interference in the Zoom format, please do not use more than one device signed into the Lunch and Learn in the same room. Now it is my honor to introduce Andy Narva, whose presentation today is entitled Changing the Course of Diabetes in Indian Country. Dr. Andrew Narva was the director of the National Kidney Disease Education Program at the National Institutes of Health from 2006 through 2019. The National Kidney Foundation honored him as the recipient of the 2018 Public Service Award for his work with Native Americans. From 1981 through 2006, he was a physician in the Indian Health Service, where he served as chief clinical consultant for nephrology and director of the Indian Health Service Kidney Disease Program. During 2002, Andy was recognized by the U.S. Public Health Service as the Clinical Physician of the Year. In 2003, he received the U.S. Public Health Service Distinguished Service Medal, the highest recognition awarded to commissioned officers. Andy is currently a full-time student in a doctoral program at the University of the District of Columbia and continues to provide care for kidney patients at Walter Reed National Military Medical Center. Andy and his wife, Yolanda Savage, have been members of MICA since 2007. Please remember to write your questions and comments in the chat function. I'm very pleased now to turn the floor over to our distinguished speaker, Andy Narva.
Thank you very much. Can you hear me?
Yes.
Good. Well, I'm delighted to be here. Let me share my screen and change to my slides. Okay. And share. And we will go to there we go. How's that looking? Okay. Good.
Good.
All right. Well, I'm honored to be here. Since I retired from the NIH, I've been attending Lunch and Learns. I enjoyed both the lunch and the learn, and I do miss the lunch still. Most of you know me, or my wife is better known, I think, at MICA, Yolanda Savage, and we've enjoyed very much being part of Temple MICA since we came here about 15 years ago. What I'm going to talk about is healthcare, improving healthcare for American Indian people. I wanted to talk a little bit about the burden of diabetes among American Indians, because that's the predominant chronic disease. Talk about challenges to improving the care of people with diabetes in the Indian community, and then talk briefly about whether or not there's something that the US healthcare system can learn from what's happened in Indian country. I will tell you that I spent the first 25 years of my career working in the Southwest for Indian Health Service. And then in 2006, I came to the NIH to direct a program in kidney disease. But I continued to serve Indian Health Service as a healthcare provider by telemedicine, and also to provide technical advice on kidney disease to the Indian Health Service. So the American Indian population is a very diverse population. It includes about 560 recognized tribes, and they're very different from each other. This is not a homogeneous population. And you can imagine if this were predominantly an American Indian country, people would say, well, what are Europeans like? And Europeans clearly are as different as, include Sicilians, and they include Norwegians. And they're very different. And similarly, it's important to recognize what a diverse community the American Indian population in the US is. There are about 5 million people. About half live in urban settings and half live in rural communities, mostly on reservations. The Navajo tribe is the largest. It's now probably close to 300,000. The life expectancy is a little bit less than US all races. And the poverty rate is much higher. This map shows, the red dots show where Indian populations live. And I hope my arrow is showing here, but you can see that most of the Indian population living on reservations that's sort of very culturally unassimilated is in the Southwest. And in fact, that's where I spent most of my career. When I was a medical student, I went to Zuni. This is New Mexico, Arizona. I was in Zuni. When I finished my training, I went to the Hopi Reservation, which is in the middle of the Navajo Reservation. And then I subsequently moved to Albuquerque here and provided care to all of the Native communities in New Mexico, sort of as an itinerant kidney doctor, and then provided consultation to tribes throughout the country. So what's happened to the health status of American Indians since World War II? Well, prior to World War II, most reservation communities were like undeveloped countries or less developed countries with high rates of gastroenteritis, infant death, and a much decreased life expectancy. But following World War II, with improved sanitation and water systems, as well as improved direct care, there was decreased morbidity, that's death, disease and mortality, death, to sort of the acute infectious diseases, the diseases that tend to spread in epidemics. But at the same time, there were changes in lifestyle. And after World War II, there was increased access to the predominant diet in the United States, decreased exercise, and there are gradually increasing rates of diabetes and other chronic diseases. This just shows sort of what happened. If you look at this red line here, that's infant mortality. And back in the middle part of the 20th century, the rates were quite high, especially compared to the US white rate, which is green. But over the next few decades, it came down, and essentially the rates became the same. So all of these sort of acute infectious problems went away, and the Indian community became much more like the US population in terms of having a much higher burden of chronic diseases. And if you look at diabetes, which is really the major chronic disease among American Indians, the rates have become quite high. They're about 13% of the white population of the US has diabetes, and this is mostly what we call type 2 diabetes, which is the diabetes that used to be called adult onset, the kind that's associated with gaining weight, and usually is not treated with insulin. If you look at Mexican Americans, the rates are somewhat higher, but then if you look at the different tribes, in Oklahoma, the rate's about 40%, and in the Southwest in general, it's about 40%. But the Pima tribe in Arizona, which is south of Phoenix, actually has the highest rate of diagnosed diabetes in the world, and 70% of adults have diabetes. And unfortunately, the other part of this is that the onset of diabetes is early, and you see obesity in children and early onset of diabetes in teenagers. And that's something we've been seeing in the American Indian community for several decades, but is now becoming a problem in the US as well as a whole. So how is healthcare provided to American Indians? The Indian Health Service is an agency of the US Public Health Service, which is part of Health and Human Services. And the healthcare that's provided to American Indians is really the only benefit that American Indian people get that other citizens in the United States don't have a right to. There are no other monetary benefits or other social service benefits provided American Indians except healthcare. And this was in exchange for giving up aboriginal lands. And so basically American Indian people gave up the country and got healthcare in return. The mission of the Indian Health Service is to improve the health status of American Indians to the highest possible level, serves about 2.2 million people, and it operates on what we could call a public health model, which I will explain. But in terms of expenditures, the money that's available to provide care to American Indian people is only about 40% of what's available to the nationally per capita. So in 2015, for example, the per capita spending on health in the United States was about $8,500 per person, right here in this second column. But Indian Health Service had about $3,100. So that's about 40%. So it's a system that's underfunded relative to the way healthcare is funded in the United States as a whole. The Indian Health Service has both direct funded facilities, which is Indian Health Service, but tribes also had the option of providing care directly themselves, and the money that would have gone to Indian Health Service to provide their care sort of goes through Indian Health Service and goes directly to the tribe. And then there are some urban clinics that provide care as well. There are about 45 hospitals, almost 350 health centers, and 111 health stations, which are very small facilities, mostly in Alaska. So the Indian Health Service operates on a public health model. So what does that mean? That means that although each individual patient, we strive to provide the best possible care to that individual, the performance of the organization as a whole is based on the improved health status of the entire population. And so Indian Health Service has actually has a model of improving care, which has been, elements of which have been included in the paradigm of how you need to improve chronic care as a whole. And in other words, some of the ideas that have been applied in Indian Health Service have been adopted and are sort of the model for how you improve chronic disease care in the United States and elsewhere. It's called the chronic care model. But in that model, the idea is that the healthcare is placed within the community. So it's important to acknowledge the community and collaborate with the community, and then to have an integrated healthcare system where all different health professionals, dietitians, pharmacists, nurses, physicians, everyone operates towards the top of what they're trained to do. And everyone is encouraged to work together to produce the best possible outcomes. So multidisciplinary clinics where you'll automatically see a dietitian or be counseled by a pharmacist as part of your routine outpatient visit has been something that's been done for a long time. In addition, community outreach, including community-based screening, patient education, community health workers are sort of part and parcel of how the whole system works. There are demonstration models of these kinds of things in academic centers, but they tend to go away after a grant ends. So diabetes care in particular is a problem, and I want to talk about diabetes care as a model of how Indian Health Service has been able to address important health problems despite being relatively underfunded. So as I mentioned earlier, there was a rising burden of type 2 diabetes in American Indians after World War II. And in response, a national program was established with standards of care. And very importantly, they started collecting data on what happened to their patients. And if you want to improve healthcare, you have to have data. Without it, you can't really do much. But they also promoted sort of a comprehensive approach to diabetes care, which meant not just taking care of people who show up in clinic, but trying to reach out to people who don't get the clinic for one reason or another, and also preventive programs, which I'll mention. In 1997, Congress did establish a special program, additional funding for diabetes for American Indians, and that provides a fair amount of funding now. So what does this involve? What does it look like when you have a program like this? Well, in terms of direct clinical care, it means that there have been diabetes clinical teams at almost all the facilities. You can see 95% here. That means that if you have diabetes, when you go to see your physician or nurse practitioner, you'll also be seen by a dietitian, you'll be seen by a nurse educator, diabetes educator, and probably a pharmacist. That there's a diabetes registry, so the patients are followed. If you're identified as having diabetes, people will keep track of you. And if you're lost to follow-up for a year, if you don't show up, somebody will reach out to make sure that you get back into the system. It means nutrition services for adults. And that's important because even if you have a private doctor in DC, the likelihood is there's no dietitian in that doctor's office. And seeing a dietitian can be very hard. But 85% of our patients have access to a dietitian. In addition, physical activity specialists are available, cultured diabetes education materials, and Indian Health Service includes a whole cadre of health educators who are generally from the community being served and who are able to really present sometimes complicated medical issues in a culturally appropriate way. In terms of prevention, there's weight management services are available to most people. And in addition to that, the only way really to reduce the burden of diabetes is to prevent people from becoming obese in the beginning. And so as a result, there's outreach to children and youth in terms of nutrition, in terms of physical activity, and that's considered part of diabetes care, is trying to do health prevention among kids that are at high risk, but who aren't identified as having any illness. So what are the outcomes? I mean, that sounds great, but if you look that over this period of time, the last 25 years, blood sugars in people with diabetes have gone down by 10%. That's a significant change. Blood pressure has been well controlled throughout that period, but the other things that affect people with diabetes are high cholesterol, and you can see cholesterol, the bad cholesterol, has gone down by 24%. And this is among about 150,000 people who are monitored. They follow on a yearly basis that many people with diabetes. And in addition, it's very important for people with diabetes to stop smoking. So a very high percentage of people have been counseled, and use has gone down a bit. It's a kind of a complicated issue because tobacco has a traditional role in many communities. Most importantly, the prevalence, which is the rate in the community of diabetes, over the past few years has finally started going down. This is a huge change and something that's not been seen in any other population anywhere in the world as far as we know. And the rate is continuing to go up, as I'll show you, in the US population as a whole. So in addition to diabetes, the diabetic complications the complications of diabetes are also much more common. If you look at kidney failure, and by this I mean people on dialysis or with a transplant, overall now the rate is about twice as high as among American Indians, but as I mentioned, it's a very heterogeneous population. So if you look at Southwestern tribes, the rate's 6.2 times higher. At Zuni, where I've been going since I was a medical student, and I just stopped seeing people there last year, the rate is about 13 times higher. So what that means is it's a population of about 10,000 people. About 5,000 people are adults over 21, and they have well over 100 people on dialysis. So 2%, that's 2% of the adult population is on dialysis. And at Zuni, that means that many members of the same family, husbands and wives, may all be on dialysis at the same time. So it was quite a high burden. If you look back when I entered Indian Health Service in the early 80s, this shows new cases of dialysis, of kidney failure. It was going up and up and up, and it looked like virtually everybody was going to get kidney failure. And so we were quite alarmed at that time. And even though I didn't have a previous interest in kidney disease, I felt like we needed to do something, and there was no kidney doctor within Indian Health Service. And this shows all the dialysis facilities on or near reservations. And there were none prior to about 1980. And this shows how many, especially in the Southwest, nearly a dozen. So there are places where there's no hospital, but there's a dialysis unit. So it's hard to improve outcomes for people with kidney disease. Not everyone knows how to diagnose it. The care is confused, is not well implemented. That means even though we know what to do, it's not always done. And many clinicians just they have a hard time implementing it, even though they are comfortable with taking care of heart disease or general diabetes. Kidney disease is scary, not only to patients, but to many physicians. One of the issues is that many people with kidney disease don't even know they have kidney disease. You can see here that only about 20% of people who have lost half of their kidney function are aware that they have kidney disease, because it's asymptomatic. In addition, what this shows is only about 4% of people starting dialysis have ever seen a dietitian. So, and nutritional interventions really do make a difference for people with diabetes and kidney disease. So I did eventually convince the Indian Health Service to send me for training. And when I came back, we set up a program to identify patients with kidney disease and monitor them, to screen for complications. Since most people with diabetes and kidney disease die not from kidney disease, but from heart attacks and strokes, we had to make sure that people with diabetes and kidney disease stopped smoking and treated their cholesterol. They got dietary consultation. And what we also had to start doing was to educate people about kidney disease and treatment, which was the most radical thing you could do, because many physicians just don't talk to their patients about kidney disease. So how do you do that? Well, we had no additional money and no additional positions. So we mobilized the existing professionals, like these two nurses, and gave them some additional expertise. And they, along with the dietitians and the pharmacists, were able to implement a program that was not fancy, but just implemented sort of relatively simple things: blood pressure control, control of blood sugar, education, in a sort of a relentlessly consistent way. These nurses are both from Zuni. So what happened? Well, if you look, if you look, this green line is the rate of kidney failure. So it peaked around 2000. And since 2000, this rate of kidney failure has decreased by 54%. And that hasn't really happened in any other group. This is African Americans, these are Hispanics, this is Asians, this is whites. It's this green line that's American Indians. And over this last 25 years or so, the rate of kidney failure has decreased by 54%. So that seemed good. We got the interest of the Department of HHS, and they have an office for planning and evaluation, and they do very rigorous, they're able to do very rigorous cost analysis and other kinds of analysis. And they estimated that as a result of these things that we did, between 2,200 and 2,600 fewer people started dialysis, and Medicare, which pays for dialysis, saved about $500 million. And that was all a function of just mobilizing the organization to do what it's very good at doing, which is providing chronic disease care. So that's wonderful, but you know, I give a lot of talks to outside communities, and especially in the East Coast and outside of this country, American Indians are kind of, you know, they're interesting, but it's a relatively small population. So why does any of this make any difference? Well, what happened, in some ways, American Indians are like a sentinel population. By that, I mean, prior to World War II, there was no diabetes among American Indians. And following World War II, there were changes in lifestyle resulting in increasing obesity, followed by the development of diabetes, followed by the development of the complications of diabetes, kidney disease, blindness, and so on. So what happened to American Indians 50 years ago is now happening to the US population as a whole. As you know, there's an epidemic of obesity, there's an epidemic of type 2 diabetes, and it's not just in this country, but it's really throughout the world. The highest rates of kidney failure due to the highest rates of diabetes in the world now are in Mexico, but it's a major problem in India, in the Middle East, and it's starting to be a problem even in China. So, it's a public health problem. So Indian Health Service is a public health agency, and it had to respond to this in a very cost-effective way. And and cost is a major problem for healthcare interventions throughout the world. So if other parts of the world are needing to intervene to reduce the burden of diabetes and the complications of diabetes, Indian Health Service, which did this in a very cost-effective way, could be a model. At least it can be offered as such. So this shows the red line here is the rates of diabetes among the US population as a whole. The blue line is the American Indian population. And as I pointed out, the rate among American Indians is starting to go down here just a little bit. But the rate among the US population as a whole is almost as high. So it's really becoming a major problem. And it is something that is a challenge to all of us. And because diabetes and its complications is a very expensive disease to treat, and it causes a lot of suffering among American people. So what did we learn? Well, it's probably best to address diabetes through what we call population management, which is programs that address the whole population at risk. And it works best if you use a model that includes the community and then engages all of the health professionals, not just the endocrinologist or not just one person, but the entire health system to work together. And that includes collecting data, finding out where you're not doing a good job and trying to improve it. It's best if you do this through the primary care delivery system, not rely so much on subspecialists like nephrologists, and have a long-term perspective. So Indian Health Service is an underfunded agency, but it's actually a healthcare system. So it may be underfunded, but it's actually a system of care. In the US as a whole, we have many examples of really good care, lots of great hospitals, lots of great clinicians, but we don't have a healthcare system. We don't have a system that really looks to address the health of all the American people. And the advantage that Indian Health Service has, and the reason that its results are so good, is because there's a system of care. It's organized, and that makes all the difference. So I'll stop there. These are the team I worked with at Zuni, and this was taken about a year ago. It is a great place to go if you want to feel tall. So, so if there are questions, you want me to stop sharing?
Yes, that would be good.
Okay. And Sid Booth is going to coordinate the questions. Sid, are you?
I'm here. Hi, Andy.
Okay.
Hi.
Everybody could turn their video back on if they want, so Andy can see who's.
Well, Andy, that was a big sandwich. It was an awful lot of data to consume.
Yeah. Sorry about that.
No. I mean, I think most of us are hearing things that we've been unfamiliar with. Maybe a few basics would be useful as we go into the questions.
Okay.
What triggers diabetes, and what should one look for as an individual? In other words, what can I see about myself, do an inventory, and make sure I'm not leading myself into diabetes?
Well, type 2 diabetes, which if we're talking about older people in particular, is often asymptomatic. And the cause of type 2 diabetes is often related to being overweight. And what happens is your body makes insulin, but when you become overweight or inactive, the insulin is not as effective. And so what you have is not a lack of insulin, but what resistance to insulin. There are a lot of older people, and may include some people in this audience, who are not overweight, but they've been told their blood sugars are a little high, or what they call the hemoglobin A1C is a little bit high. And that's in part because when you eat carbohydrate, it goes into your body, and insulin stores it in a variety of places, including muscle. And if you are not physically active and you lose your muscle mass, there's fewer places for the sugar to go, and so your sugar may be a bit higher. It's also possible that your pancreas secretes a little bit less insulin, or is less finely tuned. But in general, for older people who are having onset of diabetes, many times it's not always associated with being obese.
So we've shut in much of our population, particularly the elderly like us, are self-shut-ins. We're less active, not a very good prescription for avoiding diabetes. We need to counter that actively. Let me look at some of the questions that have come up in the chat. A personal one: what sparked your interest in the Indian population?
Well, I grew up with a book that I think was published by the Smithsonian by a man named Lafarge, which was sort of a survey of the Indian communities in the United States. And that is, I've often wondered that myself. That interested me. When I was in first grade, we read a book called Squanto, which I have no idea how it would be politically now, but when I read it at the time, it was, it basically told the story of the native people who basically saved the rear ends of the pilgrims who would have died without their help. But at any rate, the reason I became interested is that I had an opportunity to spend 2 months at Zuni as a medical student. And while I was there, I saw more physicians that I wanted to be like than I had seen even in medical school. People who were doing very challenging medicine, but also were able to really enjoy their families, in part because they lived half a mile from the hospital and went home for lunch because they could at this facility. But also, had no question about they were having a great time while really serving people who really needed them. That was very appealing. And when I went back after my residency, I assumed I'd be there for 2 years and then come back and do something more conventional, but one thing led to another.
When you grew up, was there anybody in the medical field that was a part of your family or a close acquaintance?
Nope. Well, my mom told me that 2 of her aunts were sort of barefoot doctors in Russia, but I don't really know what that meant.
I hadn't heard that term before. Question from Jerry: do the Amerindians need to live on a reservation to receive health care covered by the government?
Well, the facilities are located on reservations. If you have what's called a certificate of Indian blood, which means that you're a member of a recognized tribe, and you show up at an Indian Health Service facility, you will get direct care. But if you need to be referred out to a facility that's not part of the Indian Health Service system, they won't be able to pay for it. So in other words, if you're from Oklahoma, which doesn't have reservations, and you show up at Zuni and you have a broken leg, they'll take care of you. But if you need brain surgery, they'll refer you out, but they won't be able to pay for it. If you're from Zuni and they send you out, they will pay for it. It's kind of, the VA has a similar kind of way of working.
Well, in the looking at the matter of cost in healthcare, more broadly. You alluded to the fact that Medicare will pay for kidney dialysis. I remember when the Hartke amendment was added decades ago, creating a program for kidney care and compensation. Are you familiar with that? And I believe it has grown vastly more than anyone ever realized it might when it was instituted.
Well, yeah, I mean, prior to 1972, Medicare didn't cover dialysis, and they used to have sort of committees to decide who would get dialysis and who wouldn't, because there were limited resources. But Richard Nixon, among some of the better things that he did, established what's called an end-stage renal disease program under Medicare. And that program essentially pays for dialysis and transplant for all people, regardless of age. And so if you're eligible, if you are under Social Security, or if you're 16 and you would otherwise qualify for Social Security disability, then you will your dialysis is paid for. So actually, I did have a few patients though who never paid into Social Security, who were sheep herders, for example, and Indian Health Service paid the full amount of their dialysis because they didn't have Medicare because they never paid into Social Security.
So this, going back to a question or two, somewhat half of the certified Native Americans don't really, as a practical matter, have access to the service, the Indian Health Service, because they're not located in a place where they can get access to it.
Well, there are urban clinics that get funding from Indian Health Service. And a lot of urban people have, are employed and have private health insurance or other health insurance through their work.
Okay.
They always have the option of going back.
David Diskin asks, and I'd like to broaden the question a little bit. I'm not sure whether I just didn't get it when you mentioned it, but with the prevalence of diabetes so much higher among Indians and have gone from, low level to horrific over the last 50 years, what was the chief cause?
Well, it's interesting. I mean, there was no diabetes prior to World War II, essentially, none. So people were the same. It was really the change in lifestyle, mostly weight gain and decreased activity. And, there may be increased susceptibility to those lifestyle changes. There used to be a theory called the thrifty genotype, which meant that over, centuries and millennia, in populations like American Indians, there was selection for people who could make it through feast or famine cycles. So people who didn't die during famines would survive. And so people who had very efficient bodies who could get by with very little calories would survive. But by that same trait, if they had plenty of food available, they would actually tend to store that more readily. That theory is not as well accepted as it used to be. But it's basically a disease of lifestyle.
All right. Since it's been successful to change behavior among the American Indians, what's the chance of transferring this to the general population?
Well, I think it's, it can be done, and it is being done in some ways. It's just that everyone I'm sure on this call has very fine physicians. Is there a health educator in that person's office? Is there a dietitian? Is there somebody who does home visits? You know, it's not necessarily, it's not rocket science. It's having a way of disseminating and implementing what we know works. And, you know, sort of the largely fee-for-service American healthcare system doesn't really necessarily do that. The other issue, which is a huge advantage, is that Indian Health Service takes care of people for their whole lives. And, you know, if I could go back in people's records of people who were 60 and see their records from when they were children. And so when you have a system where the costs later on are going to be borne by the same system, there's a lot of incentive to provide preventive care. But if you have a system, as we do in the US, where you have one insurance provider, but it's unlikely that you'll have the same provider in 5 years, then why should your current provider invest in something that's expensive? Because they're not going to incur the savings. And so, you know, it really helps to have sort of a long-term view. And actually, that's one of the reasons the VA also has a lot of programs that actually work quite well, because they'll invest in prevention, because 10 years from now, they'll still be taking care of you. And if you don't have a heart attack and you don't have a stroke and you don't have an amputation, they're not going to have to provide those services.
So broadly speaking, if I understand you, the federal government has instituted 2 enormous and reasonably successful, I would say, models of community care: the veterans community, the Indians community. How is this replicated in any other non-governmental fashion in this country?
Sure, I think some HMOs, especially like Kaiser, do a good job. And but you know, they're not the predominant model for the US healthcare system.
Karen Rosenbaum asks, is there a correlation between the success of McDonald's over the world and the increase in obesity?
Of course. I mean, yeah, it's widely correlated.
When, if ever, do you expect to see a national healthcare system?
It'll be 3 weeks after we see Donald Trump's tax returns. So it's going to be a long time. You know, I mean, you can't even get a public option. You know, raising just a public option within Obamacare is considered socialism. And you know, there was an administrator of CMS who was appointed during the Obama administration, and probably the best. I'm blocking on his name, but he helped establish what's called the Institute for Healthcare Improvement, which is sort of within the Harvard system, and really knew more about how you systematically improve care than anybody. And he was named a Medicare administrator until he had to leave, because they couldn't confirm him, because at some point in his career, he had expressed admiration for the National Health Service of the UK. And that clearly marked him as a socialist, if not a communist. So
Laura Ferguson asks, if kidney disease has no symptoms, how do you get patients to get checked for it? And let me just ask, as the health consumer, we all are, how do we make sure our doctors are checking us adequately for this?
Well, you detect kidney disease with 2 pretty simple tests. One is a blood test called a creatinine. And that, if you have any blood drawn for any blood chemistries, you know, liver tests, blood sugar, sodium, potassium, any of those, they almost always include a creatinine. And as courtesy of the program that I directed at the NIH, when you get the creatinine back, you also get a calculation of the estimate of kidney function. And so that will, and there's a sort of a cutoff of where someone is identified as having below about 60% of normal function. And then the other test, which is really simple, is a urine test. And for the most part, that's just looking for protein in the urine. And that's done with a dipstick. That's also quite routine. But I mean, if you have heart disease or diabetes or you smoke, you can ask, it's quite reasonable to ask your physician or healthcare provider, you know, what your last creatinine was, and, you know, do you have any signs of kidney disease? These are not exotic tests. I mean, not at all.
Well, if you go in for an annual physical, should it be reasonable to expect that your doctor is going to look for these?
Yeah,
You're going to be on the test.
Ron, if you get, you know, if you're having your cholesterol checked or almost anything, it's almost always part of the panel, the creatinine is. And
Andrea,
urine is really, you know, it's
okay. Andrea Brown wants to know the role of genetics in diabetes.
Well, there's no single gene that increases your risk of type 2 diabetes. I'm not talking about type 1, which is what used to be called juvenile onset diabetes. But type 2 diabetes, there are a number of genes which are associated with increased risk, but it's what we call a polygenic risk. In other words, there are multiple genes that seem to affect risk, but there's not like one gene, like a gene for, you know, blue eyes that marks you in that way.
I'm getting a signal that we're about at the end, but I'd like to squeeze in one last question. It happens to come from Phyllis Posner. You didn't mention alcohol consumption. Is that a factor in the prevalence of kidney issues?
Well, people always ask about alcohol if you're a healthcare provider for American Indians, and alcoholism is a big problem. Alcohol does not contribute to kidney disease. But one thing you should remember, and I used to say this, is that there is a high prevalence of alcohol abuse in Native communities. There's also a high prevalence of teetotalers. So there's not a lot of people who drink socially and successfully. And, you know, alcohol is not, there's not really any, it has no role in traditional Indian culture. So there's no sort of, it's not like Jewish tradition where, you know, kids have a little bit of wine at Passover starting when they're like 10. So it's different. But the other thing I would mention is when I was in college and medical school in Cambridge, Massachusetts, 20% of the adult population had alcoholism, was diagnosed with alcoholism, was thought to have alcoholism. And that's a high rate. And so it is a serious problem among American Indians, but it is not, they're not unique. So.
Well, Andy, this concludes the question portion, and we're all grateful to you for your presentation today.
Thank you for the opportunity.
Thank you, Andy, for your interesting and thought-provoking presentation. Improvement in the health of the Indian population is very interesting. Adding care, including education on the lifestyle, works. Hopefully we can continue this in the Indian population and spread it to the total US and world populations. This should all lead to interesting discussions as we head into our breakout groups. Andy has provided us with questions to start the discussions in the breakout groups. These have been put up on the chat feature. I'll also repeat them to you right before we go to breakout. As always, I want to express our appreciation to Sid for his insightful way of moderating the questions, to David for overseeing all the technology that gives us the smoothly running virtual sessions, to Barbara and Jerry for all their oversight and administrative help in getting us together each month, and to all of you for supporting the program and participating with your great questions. Before we split up, I want to let you know about the December program scheduled for December 9th. We are very lucky to have Anna Greenberg join us next month as we all try to understand the 2020 elections. Anna has over 20 years of experience polling in the political, nonprofit, and academic sectors. With a little time to let the results settle, she can bring insight to what the pollsters got right and what they missed, and hopefully bring some real-time examples of how she and her firm were involved this year. Anna is a managing partner of GQR, a firm that has provided according to them, precise, penetrating opinion research and sophisticated data-driven strategies for candidates, parties, government leaders, corporations, and advocacy groups across the United States and around the world for nearly 4 decades. Once again, a plea. Please register by 5 p.m. on Monday, December 7th. Both Barbara and Jerry would appreciate this courtesy as they compile the